Hi everyone, I'm Dr. George Shenoda from Sahag, Egypt. So my case presentation, the title is We Plan to Use One but ended by more. So our patient was 76 years old female, presented by dyspnea grade 4. She is known to be diabetic and hypertensive and has a past history of radiotherapy treatment for left mastectomy for cancer breast. And her ECG was in sinus raise. Her echo, ejection fraction were 68%. She had left ventricular septal hypertrophy, severe aortic stenosis, and the area was 0.7. BG mean was 50 millimeter mercury across the aorta. So, our TAVI planning. Our annulus perimeter was 72. Our minimum diameter was 19, and our maximum diameter was 26. Sinus of Valsalva was 31.5, and calcium score was 1034, and left main height was 13.5, and RCO was 15. So, through femoral axis, we decided to do pre-dilatation by 18 millimeter balloon, and then we decided to deploy Evolute 29 millimeter valve, and this during the deployment. But unfortunately, after deployment, the valve successfully, suddenly the valve embolized in the ascending aorta and occluded the coronary circulation and patient arrested. And CPR was done. And during CPR, we tried to snare the valve, and it was so difficult. So we tried to assist that by balloon inflation below the valve. So what is the mechanism of embolization of valve during TAVI? It may be anatomical factors like undersized prosthesis, bulky calcified leaflet, paucity of annular calcification, interference with left ventricular structure like severe ventricular hypertrophy or mitral prosthesis struts, horizontal aortic annulus. It may be technical factors like high deployment, incomplete balloon inflation, pacing failure, premature pacing termination, post-dilatation of transcaster valve, second valve implantation, failure to retract the delivery pusher or resuscitation maneuver, and it may be device-related factors like failure of taps detachment or valve loader defect. So how we can deal with this? We succeeded to snare the valve above the level of the coronaries, and the patient somewhat became stable. So we decided to use another Evolute valve. We used another Evolute 29 millimeter valve and was deployed successfully. And after that, we decided to do post dilatation using 20 millimeter balloon, and that's the final result. So my take-home message: embolized transcatheter valve during TAVR. First thing, you had to maintain wire position, stabilize the valve either by snare or by optome. You must do live echo imaging to assess left ventricular function, assess other valves, and assess for effusion. You must ensure adequate anticoagulation, assess clinical stability, and consider for ECMO. If the valve is embolized in the aorta, like my case, there's a chance for percutaneous treatment. First thing, you must reposition the valve, and second, assess the new location. If it is acceptable, deploy the valve. Then you must do cause analysis. It is anatomical or procedural. If it is correctable, you can do second valve implantation. If it is embolized to the ventricle, it's probably there is a surgical rescue. And thank you from Egypt.
Okay, very good. Questions?
Can you show the CT scan to see the LVOT size? For the first valve embolization, we didn't see the LVOT size. Was the LVOT smaller than the annulus?
I can't. There's a live case.
Oh, okay.
So the LVOT was about, el perimeter was about 78 or something like that.
78. And what the first valve that you chose was 29 or 26?
Both were 29.
Both were 29.
George, what do you think happened in the first time? You used the same valve second time.
I think it was while we retracting the nose cone, it maybe detaches the valve with it. I think there's a cause, but I'm not sure.
That's why it's very important. You see, like the tabs are like totally detached, and your nose cone should not interact with the valve while coming out.